Hello everybody, my name is Jacky Edwards and I'm a consultant nurse in burns from Manchester. In this presentation I'm going to be talking about burns, and I'd like to thank Flen Health for their support in creating this event. So I'm going to talk a little bit about the management of burns. I'm going to touch on fireworks because tomorrow night is bonfire night. I'm going to talk about first aid, assessment of depth and size of burn, who should be referred, and a little bit about the type of wound management that we will use for burns that aren't being referred. So as I said, tomorrow night is bonfire night, and this is the last 5 years data of firework injuries in the UK. And no surprise to see that the 5 to 14-year-olds and the 15 to 19-year-olds are the largest group. Interestingly, there's another little peak between 25 and 34 years, but you'll also notice that they are predominantly male, with very few female patients getting injured at all. This year is going to be very different for bonfire night because there won't be any organised displays. So the government have put out quite a lot of information about how to keep safe if you're doing it yourself at home. These can be easily accessed from gov.uk, and please look at them because we are expecting a significant number, more than usual, of firework injuries this year. So if you're going to have fireworks at home, please stay safe. So hopefully the injury is not you, but you do need to know how to manage a burn injury, and the most important thing is cooling the burn. There's lots of information out there on cooling the burn, but the most effective is cool running tap water for 20 minutes. This helps to decrease the skin temperature to below levels that actually cause damage to the tissues, and it also reduces the overall depth and damage when compared to something like a wet towel. So it is absolutely the most effective way of managing any type of burn injury. Interestingly, not many people know, and this is something that's really important, if you are somewhere where you can't cool the burn, or you're a practice nurse or an ED nurse, and you get a patient that comes into you, if it's within 3 hours, you can still have a beneficial effect by cooling that burn. So if your patient hasn't done the right first aid, or they've put toothpaste or talcum powder on, or a whole range of other things that we get, then you can do some benefit for that patient by doing that 20 minutes, even if it's up to 3 hours post-injury. Ideally, it's not freezing cold. That makes the burn go deeper. So between 8 and 18 degrees Celsius, it's cooler than the actual causation of the injury. And the key thing to note is ice is not acceptable at all. Ice will definitely make more tissue damage and therefore a deeper burn, and it's actually worse than doing no first aid at all. So we need to definitely not put ice on our burns. So some key comments from that is water must be cool but not freezing. You'll actually get the patient to tolerate the cool water for longer if it's not freezing cold. Where possible, use running water because wet soaks or wet towels heat up within less than a minute, so they're not really effective. And first aid is still effective up to 3 hours post-injury. And lastly, definitely no ice. So assessing the burn depth is really important, and the most important thing absolutely is the history. The longer the contact with whatever the burning agent is, the deeper the burn. So we really need to understand from our patients that we're seeing how long was it in contact for, and then absolutely important again, was that first aid administered, and if it was it done for that 20 minutes? Was it long enough to make a difference? There's a definite rule of thumb with burns in terms of more superficial burns versus deeper burns, and the pinker the wound, the definitely more superficial it is. The whiter the wound, the deeper it is. So it's something that's we need to do a full assessment, but that's one quick way of looking at a wound and being fairly accurate. We also do something called capillary refill, which is where we press on the burn and we see the burn go white and then it comes back to its proper colour. The slower that happens, so normally that's about 2 to 3 seconds. The slower it happens, or if it doesn't happen at all, then again we can think that this burn may be a deeper burn. And the other thing that tells us that also is the sensation. So if your patient's absolutely screaming the place down and it's absolutely agony, it's very likely that that's a more superficial injury, because deeper burns have got significantly less sensation, and actually full thickness burns have no sensation at all. So it's a really good way of knowing potentially how deep a burn is. So we're going to look a little bit at the classifications. So the first thing, and probably the one thing that people sometimes don't realise, is that the redness or erythema is not a burn. It involves only the surface epithelium. It is painful. We've all had sunburn, so we know what it feels like. The key thing in burns is the amount of tissue that can leak or lose fluid, because that's what we do with burns. We replace the fluid so that the patient can recover properly. If there are no blisters, then there is no fluid loss, and therefore we don't include it in our assessment. Now, that's not to say it's not painful, because it is. As I said, we've all had sunburn, so we still need analgesia. There will potentially be some edema underneath that erythema, so it's good to feel normal skin and then have a feel of the areas that's reddened. But ideally this will just heal or disappear within 2 to 3 days. The key thing is understanding, however, that blister formation doesn't happen straight away, and blisters can form anything up to about 6 to 8 hours post-injury. So you have to be really careful that if you are thinking it's erythema and you're just going to give the patient some moisturiser, that it's not, that you haven't seen that patient too soon and that blisters might form later on. A really good way of assessing that is to actually push the skin fairly firmly, and if it gives a little bit, then it's probably going to blister. I have to say, in my clinical practice, I'm a bit belt and braces, so I would dress an erythema just for a day or a couple of days until we're certain that those blisters have not formed. So the next depth is superficial or epidermal, and that involves the epidermis only, but blistering is absolutely present. They are extremely painful injuries, but they will heal very quickly, within 7 days for adults and within 5 days for children. And because they're only in the epidermis, they won't cause any scarring. So they're just that top layer of skin. And as you can see, the picture shows you actually a patient with sunburn. So this is fairly classic, somebody that's just stayed out that little bit too long. And initially, when he was seen in the ED, he just looked like he had erythema, but he went home with some moisturiser, but over the next few days it blistered. And interestingly, sunburn actually blisters at about day 4. So it's quite different to any other injury, and that's where lots of people get caught out with sunburn. And then often they turn back up into the ED 4 or 5 days later with usually quite extensive blistering, and often require admission because they've lost a lot of fluid and they're in extreme pain. So moving up, and we're now starting to affect the dermis, or the main portion of the skin. So we've taken up the outer layer, the epidermis, and we start to get into the layer that contains things like sweat glands and hairs and sensation, your nerve endings and things. Again, there will be blisters. You can start to see that it starts to be not completely pink and it's slightly mottled. Again, it's still painful. And again, because we've not damaged all of that dermis and we're only in the top part, then it will heal again spontaneously within 10 to 14 days for adults and around 7 to 10 days for children. As we start to get further into the tissues, we start to affect the deeper layers of the dermis, and that's why we call it a deep dermal burn. And we start to actually affect the bits the living elements within the skin, so the hair follicles and the sweat glands and the nerve endings. And as we do that, these burns become less painful because we're actually starting to damage those things that allow us to feel pain. So these burns take a lot longer to heal, and usually about 3 to 4 weeks. And there's often, if you leave them to heal by themselves, quite significant scarring. So these injuries, if they went into a burns unit, would often be skin grafted, because that would be the quickest way to heal them and also give them the best cosmetic result at the end. And then lastly, as you imagine, we've gone right the way through the 2 layers of skin, and we can be in underlying tissues like fat or muscle or bone. Generally, these wounds are not painful, but they do have superficial edges. So that just needs to be thought about, because people have this idea that deeper burns aren't painful, but actually they can be. So just be careful, because there can be a lot of edges and that can be very painful. And obviously this type of injury, there's nothing in the wound that will help that wound heal by itself, and for that reason most of the time these are skin grafted. There are some exceptions, and we've got thicker skin on different parts of our body, so things like the sole of the feet or the back, often you can get quite a deep injury that will heal by dressings, but most of them end up having to have a skin graft. So this is just a pictorial image, so you can see what I was meaning about the skin layers. So you've got the epidermis and the dermis on the right hand side, and then subcutaneous tissue like fat and then muscle. And then on the left hand side you can see the epidermal burn. And then as we start to affect the dermis, you've got superficial dermal. We didn't talk about mid-dermal because it's not commonly discussed, but deep dermal, and then full thickness. So it just helps you to try and think about the structures within the skin. And as you can see, if you have an epidermal or a superficial dermal burn, all of those structures are intact. But as we start to get down to deep dermal, we're below the little hair follicles that's sticking out, and if we go to full thickness, we've damaged all of the tissue structures, so skin, the hair follicles, nerve endings, sweat glands, and those sorts of things. So hopefully that fits with what I've just explained to you. So the next thing we do with burns is we need to work out how big that burn is. And the reason that we do it is because we need to understand what the prognosis is for the patient and the treatment that the patient requires. It also helps to think about healing and ensure rapid healing, because the larger the wound, the slower it will take to heal. And in full thickness burns, as I've mentioned, a lot of the time we skin graft them, but if they're under 1%, they can heal by themselves. So understanding the size of the burn will help prevent any complications such as scarring or contracture. The problem is it's not always easy to assess that burn size. It's quite complicated sometimes, and unfortunately it's often miscalculated. And obviously people who don't do it very often are more likely to make that mistake. So I'm just going to talk very quickly about a couple of tools that will make life a little bit easier. And the first of those is what we call the palmar surface. And that is the closed hand, and the whole of that palm, including the fingers, equals about 1% of what we call total body surface area, or TBSA. So in burns, we don't measure things by centimetres or anything like that because it's too complicated, but we measure by this 1%, and that 1% is a really good way of measuring small burns or scattered burns, and is really quite effective up to about 7% total body surface area. If your burn that you're dealing with is over 7%, then it should be in a burns unit anyway. So it's good, like I say, for those small wounds, or if they've scattered or something splashed onto them, and you can use your hand as a guide. Obviously, if you're looking after a huge male and they've got much bigger hands than you, you'd have to make a little bit of adjustment. And equally, if you're looking after children, you'd have to do the same. So, but it is a good, useful tool to try and get a rough idea of whether that burn is a big enough burn that requires it to go to a burn service, or whether it's something that you can manage yourself in your clinic or in the ED. The other way of measuring burns is what we call the rule of nines. And this is a very simplistic means of looking at the body and breaks the body down into multiples of 9. So the chest, including the upper chest and the abdomen, is 18. The back is 18. The front of the leg is 18. The back, is 9, and the back of the leg is 9. So that is another 18. The head is 9, and the whole arm is 9. So the front of the arm is 4.5, and the back of the arm is 4.5. So you can see quite quickly, if you had a patient that had, say, a burn to the whole of their forearm, that would be a 4.5% burn. If you had a patient who had a burn to their lower leg, that would be a 9% burn. So it's quite a quick and easy way of assessing the size of an injury. If it's more, I suppose, if it's more confluent, if the injury's a slightly larger injury and it takes up a larger area, then this might be a better tool to use than the palmar surface. So in terms of what we need to take away from that, the really, really important thing, don't include erythema or epidermal burns in the size assessment, because they will miscalculate, because those are not going to lose fluid. The total body surface area is a guide really to whether that patient needs to be referred to a burn service or can be managed locally. And the burn depth indicates the type of wound management needed. The important thing to note is that depth will change over about 48 to 72 hours. So if you're reviewing your burn, ideally it's better not to bring them back the next day in 24 hours, but to leave them for 48 hours, and then you'll get more of an idea about the real depth of the burn. Because unfortunately, unlike other wounds, burns are dynamic and they change over time, and they'll either get better and look more superficial, or they'll look worse and look more deeper. So unfortunately, they are different in terms of that, unlike, a leg ulcer or a pressure ulcer, where it is what it is. With a burn, unfortunately, that it's not, and that's what makes them sometimes quite difficult to manage. So who should be referred? So there is referral criteria. That's the National Burns Referral Guidance, which was published in 2012. And this says that all burns greater than 2% total body surface area in children, or 3% total body surface area in adults, should be referred to a burn service. That actually means there's quite a lot of burns that you would and should be managing out in community or in the ED. Some exceptions obviously are if a burn is full thickness, then they should come, because we've said they may need skin grafting. Or if a burn is all the way round either a limb or a digit, because that may potentially affect the circulation. So those burns should be referred. And then if your burn didn't heal in 2 weeks, the likelihood is it was probably deeper, and for that reason those burns should be referred on. And then obviously any burn where there's a suspicion of non-accidental injury should be referred, and as early as possible. Within the first 24 hours, you can make quite a good educated guess about what happened with that burn. However, after that, the edges start to blur, and that makes it quite difficult to be definitive about whether that was a non-accidental injury. So they should go almost immediately. So if your burn that you're looking at doesn't meet any of those criteria, then they should be can have local care and dressings as required. But obviously, if that burn changes in appearance, starts to go deeper, or you can see very obvious signs of infection, or you're concerned that the burn is not progressing to healing, then again, you can discuss that with your local burn service. There are some other criteria where we say they may possibly be admitted, and these patients need to at least be discussed with a burn service. So if it's burns to hands, and when we say hands, we don't mean one finger or a couple of fingers. We mean, if it's the whole of the palm or the whole of the back of the hand, then they may need to come, perhaps not for wound healing, but maybe for physiotherapy or splinting. And so those need to be discussed. Exactly the same with feet. If it's a tiny area on a foot, it's not a problem. But if it's the whole of the sole of the foot, then that patient's going to have mobility issues, and also particularly with feet, they're going to potentially have infection issues as well. The face, because it might be that there is an inhalation injury, and again, inhalation injuries can be quite difficult because they can show themselves up 24 hours or more later. So again, it does depend on what the mechanism is, so it's worth having that conversation with the burn service, and they will tell you if they would be concerned. And then areas like the perineum or genitalia, because they just may be too difficult to manage in the community. Again, if it's just a small spot on a buttock, it could be fine. So it really depends on where on the perineum it is, where on the genitalia, and how much of a problem that might be for the patient to manage at home. The other things that may be discussed are particular types of injuries. So chemical, electrical or friction burns can be quite complex depending on the mechanism. So again, it's worth having a conversation with the burns unit, and they will say whether they need to see them or not. Cold injuries can be quite difficult. They often look fairly superficial, but quite quickly turn into quite significant necrotic areas. So again, understanding the mechanism, how long were they in the cold for, all of those sorts of things are really important, and that's that type of information that needs to be discussed with the burn service, and they will say whether they think that that's going to turn into a problem or not, and whether they need to be seen. Any unwell or febrile child, even if they've got quite a small burn, needs to be discussed, because toxic shock syndrome is still an issue in children with small burns, and so again they need to be discussed. And then if there's just any other things going on for the patient, it may be comorbidities, it may be that they might not cope at home. So anything at all that you think might potentially affect either the healing or the patient's ability to manage that wound, then again, do discuss that with the burn service. So if a burn is unhealed at 2 weeks, it needs referring. Superficial or dermal burns under 3% can be treated locally, and that includes superficial dermal and deep dermal. Discuss with the service any special areas or mechanisms, and consider the whole patient. Can they actually manage at home with this burn in terms of pain, function, daily needs? And if you think that that's not the case, then again, please talk to the burn service, because we do admit people for social reasons as well as other things. So let's think a little bit about dressings. These are the sort of principles that we need to think about when we talk about burns, because non-adherence is really important. We've already said how painful they are. They're extremely painful injuries. So the last thing we want to do is put a dressing on that's going to stick and cause them more pain. So they must be non-adherent. They must be easy to use but absorbent. And there is a bit of a thing with burns that people think they're extremely wet wounds. They're not really, but they are for the first 24, 48 hours. So if you bring in dressing your patient and bringing them back for review at 48 hours, that time you'll need something quite absorbent. But probably when you review them at 48 hours, you'll need something much less absorbent. We really need to maintain warmth and moisture. The biggest reason for burns going deeper is drying out. So if you just put something like an NA on with just gauze over the top, that is likely to cause the wound to dry out and go deeper. We must think about function. Function is the primary thing when we're treating our burns. So ideally we dress fingers and toes individually. We don't want boxing gloves, and we don't want people's hands, fingers bandaged together, except for in the under-2s. In the under-2s, the best way of dressing a toddler is to bandage them in a boxing glove, because they will recover their function much quicker by play than adults will. If your burn is deeper, you will need an antimicrobial. Burn injuries become infected. That's absolutely a given with a lot of these injuries, particularly, as I've said, feet, but also genitalia, perineum, hands. So certain areas obviously are more at risk, but the deeper the burn, the more dead tissue is in the wound, the more likely that wound is to become infected. So we do use antimicrobials commonly in deeper injuries. And then, as I've said, review at 48 hours initially to reassess your burn, see what depth it is, and then as required. And we tend to do our burns dressings every 2 to 3 days, depending on what we're using. And as I've said, if a burn takes longer than 7 days in a child or 14 days in an adult, then you need to think about referring that burn at that point. So in terms of dressings, it's really important to think about what your management aims are when you're trying to think about what dressings to select for your patient. So as I mentioned earlier, erythema, that's the skin is intact, there's no blistering. All we're trying to do for the patient in terms of that dressing are we're trying to alleviate pain and promote comfort and protect in case there is any potential delayed blistering or skin loss. So as I've said, you can just send them away with unperfumed moisturising cream if you're absolutely 100% certain that it's not going to blister. However, these things have a habit of coming back to bite you. So we do tend to use things like hydrocolloids on those patients, thin foam dressings or hydrogels, particularly the sheet hydrogels, all of which provide some soothing and comfort in terms of pain, but protect just in case that blister comes later. So if we move down to our superficial or epidermal burns, again, pain and comfort's really important, and we want to get them healed as soon as possible. So we want it to be in the short period of time within the week. We obviously want to prevent infection, and as I've said, really, really important, we want to maintain function. The risk of infection in those injuries is very low. So again, you can use a whole range of different things. So low adherence, maybe silicone dressings, hydrogels again, foam dressings, hydrocolloids, anything that just protects that wound for a short period of time that allows it to heal. As we start to get down into the dermis, we've got more issues. So as well as trying to alleviate pain and promote comfort, we really want to prevent deterioration of burn depth. So we don't want that wound to start to dry out, because that will start to deepen the wound. More dermis will die and over time. So we want to, again, prevent infection. We want to keep them functional as much as possible, and we want to get them healed within that 2-week period. Wounds that heal generally within 2 to 3 weeks do not go on to develop an abnormal or a lumpy scar. So it's really important for the patient that we get them healed as soon as possible, because obviously that overall outcome for them is that they want a wound that looks almost back to normal. And hopefully superficial dermal wounds treated correctly and healing within 2 weeks should do exactly that. There's a slightly higher risk of infection in these wounds because you've started to affect the dermis. So because of that, you need to start to think about what types of antimicrobial you would use. And obviously silver's a very common one. But you've got things like enzyme dressings, you've got honey, although honey in a superficial dermal burn will probably be a little bit too painful, the better in the deeper injuries. But again, you still want to make sure that you've got something that's not too adherent on the wound. So commonly used in burns are things like flamazine or flaminol, because they're cooling and soothing, but they've got those antimicrobial properties. And they can be held on with a foam dressing or a silicone dressing or something like that. As we get down into that deeper dermis, it's absolutely important that we prevent infection. The risk for infection here is significantly higher. So again, we want to try and prevent infection where we can, prevent that deterioration of burn depth, because there may be in the dermis a chance for it to heal, but if we dry that out, it'll definitely be a full thickness burn. We want to promote function, and we want to minimize scarring as much as possible. So we want to get this wound healed as fast as we can. So again, always in this cohort, this group of types of injury, we would definitely look at an antimicrobial. So again, silver dressings, honey dressing, enzyme dressings. There's lots of different types. There's lots of different types of antimicrobials. We do use quite a lot of chlorhexidine based products as well. And really they're the important thing. And then how you keep them on are your foam dressings or your silicone dressings or your low adherent dressings. And then for full thickness burns, we know we've damaged all the tissues. We've already talked about that. So what we're trying to do here is try and prepare the wound for surgical closure. So we want to absolutely prevent infection. We want to keep a good, clean wound bed where possible. We definitely want to keep the patients functional as much as possible, because when we take them to surgery, we're going to immobilise them in a splint for a minimum of 3 to 5 days, depending on where the burn is. So we've got to get them really functional before they go to theatre, and then obviously as soon as the splint comes off, we've got to get them really functional again. So again, really high risk of infection in these wounds, and again, very similar dressings as to the deep dermal wounds. There's not a lot of difference. The exception might be where we're not able to take a patient to theatre, where they either aren't well enough or they don't consent, and they've got a full thickness burn. And in those patients, we often use thicker hydrocolloids. So, for example, and I'm trying not to name names, but Granuflex is one of the ones we use. And we use that because the patient is not able to go to theatre. They may often be, in those cases, incontinent as well. And so what we find by sealing the dressing, the wound with a hydrocolloid, we are able to slowly, and it is a slower way of doing it, slowly debride that wound and remove that dead tissue, but keeping the wound intact and free from contamination. So it's not something we do very often, but it is effective if we have to do it. But obviously, ideally, we will try to take patients to theatre, because that will give them a better cosmetic and functional outcome. So just some points to note about dressings. As we've said, deeper burns need antimicrobials. Burn wounds are wet, but only for that first 24 to 48 hours, and then actually they need moisture donating, hence we use things like sheet hydrogels, etc. Deep burns still have painful edges, so they still need analgesia. And the most important thing before you start putting any dressing on is that all wounds must be washed, and all dead tissue, including the blisters, must be removed before we put a dressing over the top. So that's the end of my presentation. Thank you so much for watching, and I really hope you found it useful. I'd like to say a big thank you to Flen Health for supporting this presentation. And if you want to find out more about Flaminol and how it works, or see the evidence on safety and effectiveness, then please visit their website. Thank you very much for your attention.